Greetings and welcome to session 4 of the Lurie Children's Pediatric Virtual Roundtable Series with the Potocsnak Family Division of Adolescent and Young Adult Medicine. My name is Chad Worley. I'm your moderator this afternoon. I am the Lurie Children's liaison for the North Suburbs, and I'm joined by my liaison colleagues, Paula Nowak and Julie Kalkbrenner. In this session, we will be introducing you to Dr. Lance Nelson to discuss eating disorders. So the Division of Adolescent and Young Adult Medicine provides comprehensive services to adolescents and young adults. We accept new patients between 12 and 22 years of age. All patients are followed until their 25th birthday. Here on the slide, you see this photo. It's our Lurie Children's Outpatient Services. That's at 1440 North Dayton in the city. This is a outpatient service location for adolescent medicine, psychiatry, and behavioral health. For those of you who are not familiar with our new RAMP website, RAMP is resources for advancing mental health in pediatrics. RAMP is a mental health care reference, resource, and curriculum for pediatric clinicians. It is formed by a group of mental health specialists partnering with pediatric clinicians to expand access to mental health care. To learn more about RAMP, visit ramp.luriechildrens.org. At Lurie Children's, Respect All is a commitment. We are relentless in our pursuit of a healthier future for every child. We exist to help all children reach their fullest potential. And before I send it over to Dr. Nelson, I just want to remind you all that this session is being recorded, and we encourage you to type in your questions in the Q&A section here. You'll see on the in your panel. We do have a very large audience, so I thank you for joining us today. But because of the large audience, we're not going to unmute you when you raise your hand. So, like I said, please type in your questions, and then Dr. Nelson will gladly answer them at the end of your session. So enough of me chatting away. Why don't I go ahead and send it over to Dr. Nelson and on with your presentation.
Perfect. Let me share my screen.
Yep, looks good. And we can hear you well.
Perfect. Okay. So this is kind of a roadmap, or this talk at least is kind of a glimpse into what we do in terms of management for our patients with eating disorders or concerns for disordered eating or malnutrition. It's not all encompassing, but since the audience is for primary care providers and a lot of these patients start in your offices, I just wanted to give you a glimpse into how to manage these kids, because a lot of times, even if we are receiving your referrals, we're collaborating. So either we're seeing your patients and then we're asking maybe you to do a weight and vitals check. But often eating disorder management was not part of residency program. So you kind of might be a fish out of water, and that's why we're here to help. So just a little bit of who we are here at Lurie Children's within the eating disorder program. So there's two of us adolescent physicians, Greg Montalto, who's on this call, as well as myself. We currently have one medical social worker, Sarah Cohen. She's doing all of the medical intakes. So she's usually the first point person for your patients. We have one therapist, Kelly Horn, who's doing family-based treatment or FBT, as well as adolescent-focused therapy or AFT. We currently have a job posting for a dietitian because we're expanding, as well as a PhD level psychologist that will be 50% research and 50% clinical. So our program is expanding as we grow. Who we see, it differs a little bit on that first slide. So we see starting at age 9 and we go through 25 in our disordered eating program. We receive referrals for anyone with concerns for restrictive eating or anorexia, anyone that's making themselves sick by vomiting, so concerns for bulimia. ARFID is a newer diagnosis. It's avoidant restrictive food intake disorder. So this could be your chronic picky eaters. This is patients that might have aversion to food because it causes nausea, abdominal pain. So they're basically cutting back on their intake to prevent one of those sequelae. We also treat binge eating disorders. The only caveat is if you have a patient that's already connected with weight and wellness program, we usually recommend that they just stay with them and then they can consult with us if need be. Just a little bit of background, we see everybody, we don't turn anybody away. Right now, I'd say 50% of our patients at Lurie have some sort of Medicaid or state insurance, 50% have private. And then we do have a large Latinx population. I would say 30% of our patients have parents that are primarily Spanish speakers. All right, so what do we do first for our kids? So we typically start with getting a point of care urine sample. Again, I recognize not every primary care clinic is set up with this. If you have it, that's great. If not, it's not a deal breaker. But I just want to walk you through why we start with a urine sample. So we get a urine sample before we even weigh our patients, and we're looking for a few things. So I'm looking at specific gravity, primarily to see, is my patient drinking enough, or are they actually drinking a lot of fluids or water to try to water load or manipulate their weight? And that can be reflective in the specific gravity. And that actually is really helpful. So if a patient comes to me and their weight is up 1 pound, but I see that they're water loading, it's probably water weight and not nutritional. Or if they're up 1 pound or 2 pounds from the last visit and they're more on the dehydrated side, that actually shows, okay, they're actually getting nutrition and I can improve their hydration along the way. So that's actually really helpful for us. The other key thing with restrictive eating, as well as patients that make themselves sick, is looking at the pH. So although our patients, when they're making themselves sick by vomiting, they actually think it's just food that's coming up. But as clinicians, we know that they're losing acid, they're losing potassium. The kidneys are very smart, and the kidneys will try to compensate. So anytime that we see that the pH is actually going up, so I have a diagram here. So that patient where their pH went from 7 and then it went to 8.5, I'm actually concerned that maybe that patient is actually secretly purging because their pH is going up. And then on the flip side, if someone is abusing laxatives, the kidneys will dump bicarb or actually try to keep bicarb in. So that's actually really helpful. The other thing we look at is if someone is really restrictive in their eating and their drinking, you can see ketones that pop up in the urine. And I usually only use that if I'm concerned that I need to admit someone to the hospital for needing hydration, because that is actually one of the criteria to go to the hospital is if ketones are in the urine. Other things, since we are getting a urine sample, we care for adolescents here, so I'm always looking, is there a UTI concern? The other thing is blood in the urine is really helpful for us, especially if it's a patient that may have lost their periods or we've been tracking their periods really closely. If I see that blood pops up in the urine, that's going to be one of the questions I'm asking. Or are you on your menstrual cycle if they're a female patient? Just because we watch that really closely, especially in restrictive eating. Again, great if you have that capability in your clinic to start with a point of care urine, not the end of the world if you don't. Okay, so in our patients, they've already provided a urine sample. The next thing we're going to do is get a weight on our patients. And we do a blind weight. So we have them stand away from the reading on the scale. We have our medical assistants or nurses that are looking at the number, recording it, having the patient step off, and then shutting down the scale. The key is we also have them be weighed in their gown with a bra and underwear, female, just underwear, boxers, and males. And that's really helpful to do a gowned weight because then it's actually a true representation of where their weight is. It's also easier when you're bringing them back to clinic to assess, is this a true weight gain, true weight loss, and as well as what degree? Because a lot of our patients, if you do them in clothes, they might say, oh, my weight is down because last time I wore a hooded sweatshirt or my coat. It's tough to really keep track of that or document. Is that true? I'm not really sure. But if you're getting them in a gown, you can say, well, we always get gown weights, so this is a true representation of weight loss or weight gain. Typically, our goals are for patients to gain 1 to 2 pounds per week as an outpatient if they have anorexia or bulimia. Inpatient, it's closer to 3 to 5 pounds. I would say historically patients with ARFID or picky eating, they really struggle to increase their intake. And I would say historically my patients, my goal is closer to a half a pound to a pound per week, just because those are the patients that typically eat the same things over and over again. They're very brand specific, have a lot of anxiety about introducing new foods. And for ARFID, it's not because of fear of weight gain. It's a lot of times just because they've never had that, or they might be super tasters and they only like a certain brand or a certain restaurant's food. So it's really tough for them to increase their nutrition. So their weight gain typically is a little bit slower. The key thing when we're looking at weight is not only weight progress, but do I need to admit this kid to the hospital? And this is a unique nuance to eating disorders. And maybe you've heard about it, maybe you have not, is anybody that has a BMI that is less than 75% of the median meets criteria to go to the hospital. So it's okay if you have not heard of this. I had not even really thought about median BMI calculations until fellowship. So I have an example over here on the right. So this patient is starting to make some weight progress. Currently, their BMI at that visit was 18.1. What you do is then you scroll up to the 50th percentile, scan over to the right, and then estimate where that is. So for example, this patient has a BMI of 18.1. The BMI associated with the 50th percentile, or the black line there, is 21.8 or 21.9. You just divide the two. This patient is at 82 point something median BMI. So they're not less than the 75%. Even though their weight loss is pretty drastic, you can see that they don't meet criteria to go to the hospital. If you want to be really specific, there is a tool you can go online. It's called PEDI, tools.org. And then you look at the CDC growth calculator. It's for years 2 through 20. And there you can plug in what the sex of the patient is, their date of birth, the date that you obtained a weight, and then it'll actually calculate their BMI as well as the BMI associated with the 50th. You just have to do a little bit of hand math or pull out your calculators, and then that'll give you probably the most accurate. So that is what median BMI, if you've ever heard of it or saw it in the adolescent guidelines and you're like, I'm not exactly sure what that means, that's what they mean. So it's basically where their BMI is divided by the BMI at that age that's associated with the 50th. Okay, so we've gotten a urine sample on these kids, we've gotten a weight, now vital signs. So for us, we get orthostatic vitals. Our vitals are a little bit different than maybe you've seen in GI or even during residency. So we have the patient lay flat for 5 minutes. We get a heart rate, we get a blood pressure. We skip the sitting vitals and go directly to standing because this will actually give you a more drastic effect in your vitals if someone is malnourished. We have them stand for 2 minutes, you repeat the heart rate, you repeat the blood pressure. So why do we even care about these orthostatic vitals? Well, a few things. In malnutrition, the heart rate drops to preserve energy. The body is very smart. It tries to conserve energy wherever it is. So if a patient is only eating 500 to 1,000 calories a day and you know it's not enough, the heart is actually going to beat slower and slower to shift energy to the brain, to the lungs, to the liver, kidneys, other organ systems that cannot turn off. So we start seeing that baseline heart rate when they're laying flat dropping. The other thing is a lot of our patients are over exercisers or they're in sports and they're not getting enough nutrition for their activity. So the heart rate also drops. So if you looked at Olympian athletes, a lot of their heart rates are in the 30s, 40s, but they're well conditioned, they're getting nutrition, and it's really their heart rate is low because they've just been doing the sport for quite some time. But a lot of our patients, if they're doing a lot of cardio, their heart's going to drop, and that heart rate drops quicker if they're also not getting appropriate nutrition. We also see hypotension in our patients, so if they're not drinking enough, or basically getting enough nutrition, that drops. We also see heart rate increases from laying flat to when they stand up, because the heart is going to try to pump more blood to the brain. So we actually see a pretty drastic effect with blood pressure changes. All right, so which ones do we actually care about? Let me go back. All right, so here I've got a set of vitals for us. So on the left, there is 89/48 for a blood pressure, heart rate of 50. Then we had them stand up, their blood pressure went to 94/54, and then 74. So this patient technically is hypotensive when they're laying down. They're right on that cusp of bradycardia. And then you can start seeing that when they stand up, they are starting to see some of those heart rate changes. So what does that mean? What do I actually care about? So if their heart rate is less than 50, that meets criteria to go to the hospital. If their blood pressure lying down or standing is less than 90/45, like this patient, they technically meet criteria to go to the hospital. One of the things that actually just changed in September is orthostatic heart rate changes. It used to be an increase of 20. So in this case, under old guidelines, this kid would have made criteria by going from 50 to 74. It actually increased to 40. And that actually came about based on research looking at POTS and basically finding that adolescents who don't even have POTS often have orthostatic heart rate changes in the 20s, 30s, but over 40, it's concerning for POTS or something else going on like malnutrition. So that's why the national guidelines changed to a heart rate change greater than 40. So that's probably something new that you might not have come across. The other thing is, and we've all learned this in medical school, orthostatic hypotension. If someone goes from laying flat to sitting or standing, their blood pressure systolic drops by more than 20 or their diastolic more than 10. Again, it's a criteria. It is very, very rare. I would say I've only seen it maybe 3 to 4 times in patients. They have to be pretty malnourished. So again, it is a criteria. I definitely want you to keep that in mind, but usually patients come in for bradycardia, hypotension, or orthostasis. Okay, so we've gotten a urine, we've gotten a weight, we've gotten vitals. Say everything is fine, you've been seeing this patient, their weight is progressing, their vitals are okay, they're not going to the hospital. One of the things your patients are probably going to ask you, well, what's my goal weight? Okay. And it's one of the toughest things that Dr. Montalto and myself also grapple with is, and these are kind of our nuances, or at least this is my approach. And later on, Dr. Montalto can chime in his approach. I always give a range because if they have anorexia or restrictive eating, they will latch on to a number and they'll say, well, Dr. Nelson told me I only needed to be 115. Well, maybe that's an appropriate weight when you're 15, but maybe not when you're 16, 17, 18. But sometimes, depending on how disordered the eating thoughts are, patients don't actually recognize that. So that's why I give a range. We always choose weights that are closer to their original growth curve. So if someone's been tracking along the 75th percentile when they were younger, then they started falling off, I'm going to target a weight similar to the 75th percentile. Other things, if they're a female patient, I want to make sure that they are having monthly periods. I also want to make sure that if they lost their periods, not only did they have return of menses, but they have 3 consecutive months of menses. That's when I can say that their amenorrhea has resolved, and we're probably at a safe weight range. Are they in their goal activity? So are they only running 2 times a week, but they want to do cross country, which is 4 times a week? Okay, well, I'm going to keep in mind that. Then the last thing, and this is probably the toughest thing, and this is why everyone needs to have a therapist, is are they actually therapeutically improved? So are they having diminished body dysmorphia thoughts? Are they starting to like their body? Are they no longer counting calories? Are they having a healthier relationship with food, healthier relationship with exercise? That's when we say that they're therapeutically improved. So if you are within your goal range, which is closer to your original growth curve, you're having monthly periods if you're a female, you're in your goal activity, the eating disorder thoughts are diminished, then that's where I'm saying, okay, maybe we're in our goal range there. So how do we get there? Okay, so a lot of times you're going to be following these patients, or either after we've seen them or even in the interim before we see them. We recommend 3 meals and 2 snacks a day. I know Greg usually targets 3. I think it's tough. A lot of the area high schools have lunch at like 9:45 in the morning, so it's tough to get a mid-morning snack in. So I shoot for 3 meals and 2 snacks to start with. If they're not making weight progress, I can always add in a 3rd snack or go up on portions. So that's kind of a start point. What should meals look like? So here's kind of my virtual plate. So half of the plate should be starches or carbohydrates. So your breads, your rice, your pasta, tortillas, whatever, potatoes. Only a quarter of the plate should be protein. So that can be peanut butter if it's breakfast, it can be eggs, it can be beans, it can be meat. And then a quarter of the plate should be fruits and vegetables. A lot of patients, that fruits and vegetables are taking over half the plate, 3/4 of the plate, or all their plate. So I usually say I value fruits and vegetables, you need them, but only a quarter of your plate should be fruits and vegetables. If you're cooking meat or pastas, you should be cooking with oils, butters. A lot of patients, if they're have anorexia or restrictive eating, they're fearful of fats. So I usually just say the brain is made up of mostly water and fat. If you don't give the body will go looking for it, and it will break down brain tissue. It will break down tissue elsewhere. It is important for your recovery. And then there should be a dairy product somewhere. So it can be a glass of milk, it can be yogurt, it can be cheese. So that's kind of what the meals should look like. If they are an athlete, I do recommend that they should be having 3 snacks a day during their season to keep their weight stable, or at least still climbing. The other thing with my snacks, they should have 2 to 3 items. So, and I'm kind of cruel a little bit, I don't count fruit or vegetables as a component, because you'll have patients come back and say, well, I had 2 items. I had strawberries and a banana, or I had carrots and celery. So I say, well, you can have fruits, but it should be like a yogurt with berries and granola. The yogurt, the granola counts, the berries are just in addition if that's what you want. The other thing is, initially, parents should be plating all meals and snacks. Again, I use the analogy because if you let your patients do it, it's almost like a patient that's gotten pneumonia, and you're asking the patient to go to the pharmacy and, 1, choose which antibiotic to take and how much of it. They'd be a fish out of water. And then you bring them back in a week and say, oh, did your pneumonia clear? And they're like, no, because I didn't know really where to start. Similar with patients. They are triggered by food. So asking them to plate their food initially they might spend hours either planning the meal or hours after the meal distressed about the meal. So that's why we ask parents to plate initially and control portions. Over time, as the adolescent recovers, then they might plan a snack, they might plan 2 snacks, they might plan breakfast and their snacks. And eventually, depending on the age, if they're 16, 17, 18, they might get more autonomy than an 11 or 12-year-old. That's just kind of the general rule. The other thing is I just use kind of a quick rule that each meal counts as 2 bottles of Boost or Ensure Plus. So if a patient only eats half of what their parents are plating, they still need 1 bottle of Boost or Ensure. And then each snack counts as 1. So again, 50% of a snack, they need 50% or a half of a Ensure Plus or a Boost. So that's where meal replacement comes in. So it's just kind of just some start point recommendations for meals. The other key thing that you probably get asked about of, can I do PE? Can I do cross country? Can I do volleyball? So here's my general approach. And my caveat here is there is not an exact science here. So there's not guidelines that say volleyball 2 days a week is the equivalent of tennis 3 days a week. So here's where I'm at. If I have a patient that is actively really low weight or close to being admitted, probably not a good idea to throw them into exercise or activity and hope for the best. So I pull activity if they're really low weight or really close. The other thing I consider is this patient losing weight or gaining weight? So if a patient is losing weight and they're not in activity, probably not a good idea to add more activity. Are their vitals stable? So this is key. Like, is their heart rate still dropping? So say you saw a patient and their heart rate was 70. 2 weeks later, it's 60. Then it's getting into like 55. Might be time to pull back on some of the cardio or some of the activity because they're inching closer and closer to going to the hospital. If they're not really low weight, they're not close to being admitted, they're gaining weight, their vitals are stable, then here's my general approach. Are they in PE class? Because PE is my first thing, because there's a credit involved, schools are watching, and it's tough to say, no, you can't do PE, but you're in dance 3 days a week, or you're in volleyball practice. So I give them PE first, usually just a few days a week. Then if I bring them back in a week or 2 and they're doing well, then I might give them either a few more days a week or full activity clearance, depending on how they're doing. Say the patient's in full PE, they come back for their next visit, they're doing really well. And then I might clear them for walking, light weightlifting, so not squats, not bench press, anything that they have to like hold their breath. So light free weights, something like that at the gym. I do that 2 to 3 times a week. Bring them back in a week or 2, see if they're doing well. I might increase that to 4 to 5 times a week. Bring them back in a week or 2. Then I start introducing cardio, or if they're in a sport and they want to do drills. So I have a patient that really wanted to get into basketball and his team is like actively playing. And I said, you know, you can go, you can do the shoot around, you can practice free throws, you can practice layups. I just don't really want you running down the court. I don't really want you playing in games, but I do want you to get to play basketball. So maybe 2 to 3 days a week of that. And then you just keep advancing and advancing depending on how they're doing. The key thing here, and it is what I tell families, usually I'm seeing them every 1 to 2 weeks, depending on availability. Not really because they're medically unstable, it's more because I want to get them into their activity quicker. So if I'm seeing them every 3 weeks, every 4 weeks, then they're at that same activity for 4 weeks. So that's why I bring them in pretty quick. I hate pulling activity unless they're really close to being admitted. I try to meet patients where they're at and then advance from there. I focus on nutrition. So we've got to do 3 meals. We've got to do 2 snacks. If that's not working, then I might have to back off on some activity. But again, I focus on the nutrition piece. So add another snack if you're only doing 2 snacks, go up on different portions. And I think the helpful thing there, just do a diet recall. So ask them what they're having for breakfast, lunch, and dinner. What are they doing for snacks? Because I think that's really helpful, because they might say, oh, I'm doing 3 meals, I'm doing 2 snacks. And this happened earlier this week. Well, breakfast for a patient was a banana. So I think when you get the 24-hour recall, that's really helpful to say, well, why don't you add this? Or why don't you do this? Or 2 pieces of this, come back in a week or 2. If you're doing well, okay, I'll keep you in that activity or advance it. If you're really struggling, then that's when I might start pulling back just a little bit. And again, circling back, there's not an exact science. Also, even if you've got 2 volleyball players right next to each other, maybe one is doing it more recreationally, and then another person's on like AAU and competitive travel. So it might be a little bit different. You know your patients the best. Use kind of your gut feeling that they might be over-exercising. And then just see them every kind of 1 to 2 weeks if you have the capacity. And kind of go from there. So I think that's kind of what I've got.
Thank you, Dr. Montalto. We do have a couple questions from
Yeah.
our audience today. I'm going to start off. Well, first of all, I just wanted to mention that our RAMP curriculum, www.ramp.larrychildrens.org, does have a whole section on eating disorders and some other resources for primary care providers as well. So that's something great to check out. They're in perfect size increments, 10 to 15 minutes each section. So one of the questions is, do we need to worry about refeeding syndrome?
Yeah, so great question. And one of the things, and I would say patients that are really at high risk of refeeding syndrome are patients that are eating less than 500 calories a day. So doing that diet recall is really helpful. Also, if someone is very, very low weight, that is one of the things. And that's why a lot of times we admit patients to the hospital if they're really low weight, because we know that that risk is really high, especially in the first 5 to 7 days. But I would say patients that are eating, say, like 1,500 calories or more, pretty low risk, and doing it safely at home. And again, I think that this discussion was like ideal. It is a painful struggle if you've taken care of a lot of these patients. A lot of patients in the first few weeks or months are going to really struggle to embrace the 3 meals and 2 snack idea. So they might not be doing any snacks, and then it becomes that they add 1 snack a day, or maybe they're doing 2, but it's only 1 item. So actually, a lot of times patients slowly ramp up themselves at home, so it's safe to keep them at home. The patients that get themselves into trouble are if you have anyone that's purging. And I didn't cover electrolytes here, trying to condense it to 15 minutes. But if you have a patient that you know is making themselves sick, I would get a set of electrolytes looking at potassium. And our goal is to keep it at 3.5 or greater. If there is a patient that's under 3.5 for potassium, that meets criteria to come to the hospital. The safe thing to do, and if you're really worried about a kid, is bring them back in a week, get a set of electrolytes, and do that for a few weeks to see, is my phosphorus dropping? Is my potassium dropping? Is my magnesium dropping? And if it is, we welcome any call. You can always call adolescent medicine on call to just say, I've got this patient, they don't really meet criteria for weight. Their potassium was 3.8. I brought them back a week later. Their potassium's 3.5. I'm really worried about this kid for refeeding. We're happy to discuss, like, does that kid need to be admitted just to make sure that they're safely monitored for nutrition? But it is that big kind of scary risk of, are they going to develop this at home? Yeah, again, there's not really an exact science. But like I said, a lot of times doing 3 meals, 2 snacks is the ideal. and Dr. Montalto is on this call, I would say very rarely are families going to go home right away and like ramp up calories by like 1,000 per day. Usually in the first few days to weeks, they're really only adding maybe a few hundred calories a day. And then, which is safe because in the hospital, we actually go up by 300 per day. So it's a
Okay,
great question.
thank you. Another question is, how do you incorporate vegetarian or vegan dietary preferences into your meal recommendations?
Yeah, so I think the key is looking at the patient's history. Have they been long-standing vegetarian or long-standing vegan? Are they being vegetarian and vegan but maintaining their weight? I think that is key. I have a lot of patients that have been vegetarian since they've been little kids. The family is vegetarian, and that's fine. But then it melds into veganism and feeds more into the eating disorder. So I always look at the timing. Same with vegetarianism. If they've always eaten meat, and then all of a sudden they have body dysmorphia and now they're being vegetarian, that's the eating disorder. So then those are the patients that I actually say, no, we need to be incorporating meat back into the diet. If someone is longstanding vegetarian, but then they've melded into vegan, I tell them like right now during your adolescence, it's critical for growth. You can be vegan down the road once you've like done growing like in your 20s, but in your teen years, it is very tough to get appropriate nutrition as a vegan. So I will honor the vegetarianism, but I can't entertain the vegan. And also like, how are we going to get appropriate nutrition? Because again, the other thing it's key is if they're vegetarian, are they also cutting out sweets or fats? Are they cutting out carbohydrates? Are there other disordered eating habits that are melded in? Because that's where you want to ramp up nutrition. So you can be a vegetarian, but you need to have a half of a plate that has either rice or pasta. Your protein source can be beans, but it can't be all fruits and vegetables. I think that's the key. A lot of our patients, their whole plate is fruits and vegetables, and they say, I want to be a vegetarian, because in their brain, that is what being a vegetarian is. There's a lot of ways to get nutrition in that's well balanced. Protein source is peanut butter in the morning. So you can have a patient that has 2 slices of bread with peanut butter on it, sliced bananas on it, and a glass of milk, and they can be vegetarian that way. But if they're switching out cow's milk for almond milk, rice milk, all these milk alternatives, they're not willing to do peanut butter, they don't really want to eat carbohydrates with bread, then that's more disordered eating and not being a vegetarian, if that makes sense. So
Okay, and then do protein bars, protein shakes fit into that as well?
So it's really tough. I'm fine with protein bars or doing like the Fairlife protein drinks. I really try to stay away from protein powders. Our kids are developing, it's a big load on the kidneys. There are so many ways to get natural proteins. And honestly, if you look at the AAP recommendations in terms of like protein supplements, creatine, all the other supplements, if you're eating a well-balanced diet, we get enough protein sources in. Like there are great protein sources in meats, yogurts, beans. So I try to encourage patients to get their protein source through their solid food and not protein drinks. And if they are going to do a protein shake, I usually just limit it to like 1 a day, is kind of my philosophy on it.
Thank you. Okay, we have a couple questions on the other side of the spectrum with overweight and obesity. What if the patient was overweight or obese before the weight drop?
Yeah, and I think that's kind of where disordered eating and eating disorder, there's kind of some hot debates about it. Do you get them all the way up to their original growth curve? Do you not? I think some of the key thing is, and I think this is why it's helpful talking with primary care physicians, you know your patients. So is there a risk of prediabetes or diabetes in the family? Did the patient already have issues with their cholesterol or hemoglobin A1C prior? If they did, because a lot of times patients have already had their like 9 to 11 lipid screen, if there's already some concerns, probably not ideal to get them back to that exact weight. My approach, all adolescents should still be doing the 3 meals, 2 snacks. But again, it should be really balanced in what they're doing. So following the plate model. I deviate a little bit on my snack policy. So what I do for someone that's overweight, and we're kind of balancing that out, I want them to still have 2 components, but I usually actually encourage fruit or a vegetable as one of the components. So that's kind of where I shift a little bit in my dialogue. But I still want them eating 3 meals a day. I still want them eating 2 snacks a day. And the reason why is that also helps cut down on binging behaviors. And then I'll also tell families, and you can do it in your clinic too, is ask them what they binge on. Like, what are their trigger foods? So if it's frozen pizza, probably not the best idea to keep a lot of frozen pizzas around. If it is chips, what I'll have is patients, because chips is a pretty common one, is buy the individual bags of chips or buy the like family size and then put serving sizes into Ziploc bags and put it in the pantry. We don't really touch on binge eating disorder, but similar approaches. I usually tell families to make your meal, make your snack, and then take it to a table or a different room and not kind of graze by the pantry, the refrigerator, eating out of the container. Because like all of us, it's a slippery slope. If I bring like the bag of Oreos over to the couch and I'm like, oh, I didn't intend to eat 9 of them, but I did. Okay. It's okay. But it would be probably nice for the adolescents to like, okay, a serving size is 3 or 4. Okay, let's put those in a Ziploc bag. I know it's easier to keep track of like how many actual servings you had. Same with like chips. We've all done it with the tortilla chips and eating salsa or whatever. If you're eating just right out of the large bag, it's tough to keep track of exactly what it is. But if you buy that and you put it into containers or whatever to keep it stored, that's actually really helpful to just be more mindful of maybe how many servings you're having to reduce those binges. Other things like grapes. I think another good one, if they do like fruit, like strawberries, grapes, blueberries, things that they can eat, like lots of things, can also be a strategy there. So it kind of maybe feels like you're getting a large portion, but something maybe is not as energy dense. Similar, I like prefer that families do like yogurt cups that are already in individual sizes versus like kind of maybe the tub of yogurt, because it's tough to keep track. So hopefully that kind of answered the question on the opposite spectrum.
Okay. And then I do have one last question. What about prematurity? Does that factor in?
In terms, I don't know if people can unmute, kind of more detail around the context of, are we talking about like just younger kids or?
I'm thinking if they've just been underweight.
Yeah, kind of a long-term.
To start. Mm-hmm.
Yeah, so we see that commonly in ARFID, is kids that are always low weight. They have different weight goals. So again, we're trying to get them back towards their original growth curve. But for some kids, that is like the 3rd percentile, the 5th percentile. One of the things is if a kid is having stable vitals, they're really low weight, happy to discuss over the phone or send us a referral. Sometimes what I'll use is the patient at least 75% of the way to their weight goal? Because it doesn't make sense if a kid has always been at the 1st percentile to use the 50th percentile. But say maybe they're at negative 10th percentile or however it works. If I divide that by, so that weight there divided by the weight associated with the first percentile, well, that might be that they're 90% of the way to their goal or 80% of the way. That actually makes more sense than saying a kid is 58% or 60% based on the median BMI, because they've never been anywhere close to the median BMI. So how do I get them closer to their goal? Other things that really help with that determination, if it's a female with ARFID or really low weight, are they still maintaining their periods? That can be a sign that they're maybe not as malnourished. Again, not for this talk, I didn't talk about labs, but looking at thyroid function, if you get a total T3, if that lab that you get is normal, that actually is really helpful as a tool that maybe they're not as malnourished as I once thought. So I've actually used that a lot in kids with ARFID. I'll get a TSH, a free T4, and a total T3. If things are normal, their testosterone is normal in a male, or they're having periods, that's when I go back to the drawing board of, well, maybe their weight goal is a little bit different because they're maintaining their blood pressure, their heart rates, everything lab-wise is fine. They don't equivalate to someone that might be like 58, 60% based on the median. So maybe that's where I go back to the drawing board of let's choose a lower weight goal and they have kind of their own individual goal percent, if that makes sense.
Thank you. Chad, I'll turn it over to you to close it out.
Yeah, you know what? We've gone this far, so let's go ahead and there's that one last question in there, Julie. Let's just go ahead. It says, am I supposed to be concerned about the formerly obese kid who drops a lot of weight, but are now normal BMI if parents are concerned?
Yeah, so great question. Whoever asked that, that's kind of
That's
one
what I thought.
of those.
That seemed like a good question to close with.
And it's probably the golden question that has triggered a lot of discussion around, should we even be using the median BMI question for admission, or should we be using degree of weight loss? I will say a lot of patients who have lost a lot of weight, but are quote unquote normal BMIs, usually have some sort of vital sign compromise. So their heart rates are really low, their blood pressures are low, and they meet criteria there. One of the things that we also will do is admit kids here at Lurie for what we call failure of outpatient management. These are usually kids we ideally would want you to either like send to the ED or send a referral to our clinic to make that determination. But I've admitted kids before that if you looked at their BMI, they're at like the 100th percentile. They're like right at the 50th percentile. But they used to be at like the 125th percentile for BMI. They've lost significant amount of weight. They've lost like 80 and 90 pounds over a 6 to 9 month period of time. Those kids probably need to be connected with us or admitted to the hospital because one, they're probably some of the highest risk of refeeding syndrome. And two, maybe their disordered eating thoughts and behaviors are more extreme than someone that is a lower weight, but maybe started at a lower weight. So maybe they've only lost like 20 pounds, not 80 pounds. But it is tough. And I know Greg's on the call. Those patients often get diagnosed with something called atypical anorexia nervosa. The only thing atypical is that they have a normal BMI. They have all the behaviors of anorexia. So that's another, and Greg and I are kind of aligned. We just diagnose them with anorexia nervosa because they're treated the same. Therapy with family-based treatment is the same. Medical management is the same. So we just call it anorexia versus atypical because there's really nothing specifically atypical about it other than their BMI is at the 60th percentile versus someone that's maybe at the 20th or 15th percentile. But it's a great question.
So if our community physicians have questions like this, they can call you, they can
Yeah, so they
contact.
can call. There's always an adolescent medicine.
So that number, the 312-227-6800 is probably the best number
Yeah,
for.
so they can get connected with, who's on call.
Or
Yeah.
Lurie MD. Lurie
Yeah.
MD is also an option.
I was gonna say
So
Lurie
there's
MD, yeah.
always a fellow or an attending that's covering these
Mhm.
patients. The other thing is, and this is something that I'm really proud of our program, when patients get a referral to us, we're pretty good about at least getting an intake with Sarah Cohen, our social worker, within 1 to 2 weeks. So, and she's really good about connecting since we're small. Once she does an intake, she connects with Greg and myself to say, this patient is very worrisome. And sometimes we've even just called right back and say, this patient actually should probably go to the emergency room. Or can we try to move things around and try to get them in? Again, it is tough because there's only 2 of us. And that's why hopefully this visit was helpful, because we're going to be partnering with a lot of community physicians out there to manage these patients. But we do our best. But yes.
So let's talk about that real quick. Location wise, so are you just at Dayton? Are you at the hospital? Why don't you talk about that really quick? I mean,
Yeah.
so they have an idea.
So we're at Dayton Street, kind of North Clybourne area for our physical location. We also have an inpatient service. So right now patients get admitted to general pediatrics and then adolescent consults every day on the patients. Hopefully down the road, we'll be moving towards more of a primary service, or at least a protected unit, maybe of like 5 beds or so for disordered eating. One of the things we try to do, and Greg and I do this, is usually we bring them in person to our Dayton clinic the first time. But if it's a patient that's further out in Illinois or even the suburbs, we do offer telemedicine visits. If that's the case, what I usually do is I'll send patients with a 1 sheet that basically says, we want a urine sample. If you can do it, we want a gowned weight. We want these vitals. Here's where to fax it to us. So either you see your pediatrician or family doctor the day before, and it can just be a MA or a nurse visit. Get the weight vitals, they fax them to us, and then we do a virtual visit off of that. So I've got some patients that are up closer to the Wisconsin border. They go down the street to their pediatrician, get weight and vitals, they fax them to us. They don't drive down to Chicago. We use that data and put in our recommendations.
And Dr. Nelson, you've helped me with a question, and I think some pediatricians may also need to know how should they manage patients that are younger than 9 years old?
Yeah, that's a tough thing. Every institution does it a little bit different. I would say a lot of times these are patients that when they're younger are managed by GI, or Lurie also has a feeding clinic. So if it's an ARFID kid that's been chronic picky eating, they are seeing through 8, but don't see at 9. So that's kind of where we've discussed as a division, and Greg's on this call, it becomes a slippery slope. We've seen 9 and up just because a lot of other places will not see adolescents. But kind of the younger we go, then it's like, where's the exact age that we start? So we've kind of started at 9 just because we know they've aged out of the feeding clinic for ARFID there. And often once they start getting into adolescence, if it's malnutrition, GI kind of also wants to send them elsewhere. Also, we just have to be kind of mindful of our capacity, just being pretty full, just seeing adolescents and young adults. Because on the opposite side, most places don't see older than 18. So us seeing 18 through 25 are kind of a home for them. So I would say kind of coordination. The younger kids it's also tough kind of what their history is. Is it like truly like restrictive eating? We're concerned about anorexia. Has this been long-standing picky eating? So is this a kid better served by the feeding clinic, which takes care of kids with feeding issues? Is it a kid with malnutrition that's been followed with GI because they've got a G tube or an NG? Yeah, and then just a lot of close follow pediatricians. But I think that's, and Greg, I don't know if you can chime in, but I feel like it's been mostly feeding clinic and GI for the younger kids.
Yeah, no, I mean, it really, I think the biggest question is, what is their diagnosis? Kids with avoidant restrictive food intake disorder, or ARFID, we're not really well set up, particularly for younger kids, to really help much with that. We do get kids. I've had a few 7 and 8 year olds who have straight up anorexia nervosa, and that's a different story. Usually the younger kids are more ARFID, but if there's somebody with anorexia, then it's worth picking up the phone and chatting. But for ARFID, yeah, we're just not equipped to do that, is really the biggest point.
Well, I'd like to thank you guys for being on the call today. This was a very great discussion, to be quite honest with you. Based on the participants that are on here, the questions that were asked, and the detail that had to go into those questions, it's very evident that eating disorder is on top of mind for a lot of people and for most of our pediatrician partners. So for those of you who are still on the line and you have more questions, feel free to pop them over to your liaison, and we'll be able to share them with Dr. Nelson. Or, as we mentioned, Lurie MD is available. We have the 312-227-6800 number that you see there for adolescent medicine. For those of you watching the recording, I'd like to thank you for being on the recording. And then right below is the link to the Lurie Children's Adolescent Medicine Department. You can click on that for more information. But again, thank you everybody for being with us today. I'd like to remind you that tomorrow, session 5 will be at 7:30 a.m. with Dr. Marai Rashamandar and Lindsay Ellers. They'll be discussing the effective screening for substance use in a busy practice. So I anticipate that one to be another highly attended session, and come prepared with your questions. But until tomorrow, have a great day, everybody, and thank you, Dr. Nelson, Dr. Montalto.